Good morning, one and all. My presentation is on analysis of case series of hemifacial spasm. I have no financial disclosure. Giving a brief introduction, it is characterized by, sorry, one second. It is characterized by unilateral contraction of the muscles innervated by the ipsilateral facial nerve. Its prevalence is about 9.8 per 1 lakh persons, according to studies by Nielsen et al. It is the disease process of the nerve root entry zone of the facial nerve. Based on the etiology, it can be categorized into primary and secondary hemifacial spasm. Primary due to vascular compression of the nerve root entry zone of the facial nerve. It is more prevalent compared to the secondary, common in the 5th decade. A secondary hemifacial spasm can be due to any trauma, tumor, demyelination, or vascular insults to the facial motor nucleus or the peripheral course of the nerve. It is diagnosed clinically, and imaging modalities help in confirming the diagnosis and differentiating it from any other movement disorders or ruling out any secondary causes, and they help in intraoperative planning. Management can be medically by injection botulinum toxin or surgically by macrovascular decompression. In neuroimaging, the aim of the study is to detect the etiology, and the need of MRI in all HFS cases is discussed in the study. It is a retrospective short case series involving 26 patients who presented to our neuro-ophthalmology clinic in a 3-month duration with hemifacial spasm. The mean age of presentation was 53 with a male-female ratio of 1:2.3. Meanwhile, 2 patients with secondary HFS presented at comparatively younger age. They presented with twitching involving periocular area, angle of mouth over a mean duration of 1 to 2 years. Headache was seen in 6 patients, associated in 6 patients, and systemic hypertension was associated in 2 cases. Based on the MRI, they were diagnosed with primary hemifacial spasm with neurovascular conflict in 63% of the patients, and secondary causes were seen in 9.1%. The MRI was normal in 27% of the cases. In the neurovascular conflict, posterior inferior cerebellar artery was involved in 50% of the cases, and anterior inferior cerebellar artery in 33%, and vertebral artery in 16% of the patients. In patients with the secondary HFS, this is the MRA contrast showing CPA angle tumor diagnosed as vestibular schwannoma. The other patient found to have cavernoma in the left temporal lobe with marked GRE blooming. All the cases with primary HFS were treated with injection botulinum toxin. Secondary HFS were referred to neurosurgeon for further surgical management. Coming to discussion, HFS is characterized by tonic-clonic contraction of the orbicular oris, causing involuntary eyelid closure and eyebrow elevation. This contraction progressed to the regions affecting frontalis, orbicularis oris, and platysma. This sustained contraction gives severe disfiguring grimace with partial closure of the eye and lifting of the mouth corners. This helps in clinical diagnosis of the HFS. Primary HFS, as per previously concluded studies, it is due to vascular compression of the facial nerve root entry zone in the posterior fossa. AIOC was the most commonly involved arteries according to the previous studies. The causes of secondary HFS, as discussed by previous studies, can be anywhere from the facial nerve nucleus or from the internal carotid auditory canal to the stylomastoid foramen. These previously conducted studies concluded that primary hemifacial spasm is more common than the secondary, and these are the various causes found, like a CPA angle tumors like schwannoma or any meningioma, and demyelination or any vascular conflicts. MRI and CT angiogram is done in all cases, and they help in clinching the diagnosis and differentiating primary from secondary. This is 3D reconstruction image showing the right pica causing the right hemifacial spasm in this case. Hemifacial spasm has to be differentiated from other facial movement disorders. The standard medical management is botulinum neurotoxin. It is a treatment of choice for patients with high anesthetic risk and who refuse surgery. Anticonvulsants such as gabapentin are less effective, and they provide symptomatic relief in early HFS patients. Microvascular decompression is the treatment of choice. The underlying principle is to separate nerve vessel conflict. Aneurysms are treated with an endovascular coil embolization. Cases with secondary HFS, in addition to microvascular decompression, tumor removal was done. Latest interventions such as gamma knife surgery and stereotactic radiosurgery were performed by the neurosurgeons. With prominent clinical manifestation of HFS are best treated with decompression of the relevant point of symptomatic compression. Thus concluding, the primary HFS is more common than secondary in accordance with the previously conducted studies. Though secondary HFS is rare, the underlying pathologies can be grave and life-threatening. Patients with CP angle tumor can present initially with hemifacial spasm and they come to ophthalmologist only. Thus, we are emphasizing the need for MRA with the MRA in all HFS cases. These are my references. Thank you.
Haritha, it is really appreciable that you've done MRI with MRA in all the cases, am I right?
Can you stop sharing your screen?
Yes, sir. Yes.
MRI with MRA was done in all your cases, right?
Yes, sir.
Yeah, so that's really appreciable that you went all the way to look for the etiology. And it is also interesting that you saw 26 cases of HFS in 3 months, right?
Yes, sir.
Okay, so that means that you are a really important tertiary referral center for such cases. So I think you should do a prospective study and you should publish your results because you're showing 50% or more etiology, you know.
50% or more, sorry, sir.
62% you said have an neurovascular conflict.
Conflict as the etiology, yes, sir.
But literature does not report that, so you have to report this. You have to make a publication, do a prospective study of the whole year, one whole
Yes,
year,
sir.
and follow up. Okay.
Yes, sir, sure, sir. Network bandwidth is low. Sorry.
All right. Thank you. Thank you, Dr. Haritha.
Thank you, sir.
Thank you, doctor. It was a wonderful session.
Thank you, sir.